important to know that I will describe it in an order of occurrence because we are learning from them, especially our first case that we show you. I will talk about the management and diagnosis of patients that evolved with limb ischemia after COVID-19 infection. And our first case, it's a 27-year female, right, that presented a Sunday paresthesia of the right hand and forearm. She had a COVID infection 30 days previously of that day, and her presented a coldness of the fingerprints associated with cyanosis, but she is still presenting a radial pulse, and she had a slow tenor perfusion, as you can see in this picture. I think you can notice what I said. And she went to a Doppler ultrasound that showed no flow in the digital arteries indeed. It was initiated full anticoagulation with low molecular weight heparin and underwent a therography, which showed, as you can see, that was being retained contrast on the muscular arteries of the forearm. And in that image, you can see that the contrast being retained in the radial artery and no contrast filling the hand. So we decided to get her on an infusion of fibrinolytics because we don't identify any kind of failures of blood supply, thinking about a acute thrombus in her arteries. And after 6 hours of the infusion, the patient reported reduction of the paresthesia, but the angiogram, as you can see, got worse. Still not feeling contrast of the hand of the patient. So we tried switching the infusion to intraarterial heparin, unfractionated heparin, which was maintained for 24 hours, and start intravenous corticoid therapy. After 24 hours under observation in intensive care unit, the patient returned to angiography that showed complete filling of the entire arterial network of the right upper limb. Can you see the difference, right? And the aspects of her hands get better as the symptoms. So we decide to maintain her using low molecular weight heparin, observe it for 48 hours, and get discharged after, and maintain it and observance for 45 days using oral anticoagulation with rivaroxaban. She got long paresthesia, but after 12 months, she got better from that. As you can see, the day of the discharge, the perfusion was better. And the second case, 44 female patient, and she got to the emergency showing paresthesia and cyanosis of the left hand. She had two COVID infection 15 days previously of that day, and on physical examination had palpable radial pulse and low perfusion of the hand. She underwent arterial Doppler ultrasound, which showed that it was normally the flow of the radial artery, but in the digital arteries it was a reduced flow. So we started intravenous unfractionated heparin and methylprednisolone every 12 hours. After 24 hours, she had an improvement of her paresthesia, and after 48 hours, She got an episode of epistaxis, so we reduce the flow of the intravenous heparin, and she didn't present any other kind of complications, being discharged of the fourth day once her symptoms had improved significantly and was maintained under ambulatory monitoring of 20 milligrams of hydroxyban per day for 45 days too. And the case three, that was a 38 years old female that was complaining that the emergence of pain in right foot about 14 days earlier, worsening of the previous 24 hours. She had had COVID-19 infection around 30 days earlier, and on examination, distal pulse of the limb, the right lower limb, was absent. So, and the perfusion was low, especially in the plantar aspect of the calcaneus. She underwent a Doppler ultrasound, revealed signs of occlusion in the tibial and dorsal peds arteries, and a slow perfusion along the plantar aspects. So we started heparinization with unfractionated heparin. We started corticoid therapy too, as well. We just had learned with the first case we went through. In the fourth day of her after her admission, get discharged, maintained rivaroxaban and ambulatory monitoring. It's different from the other case because she get us less earlier of the previous two cases. So she maintained symptomatic after 4 months, being underwent Doppler ultrasound with not occlusion in that moment, but due the symptomatic she was presenting, she was performed another angiography that it was performed a percutaneous angioplasty because they are presenting, if you can see, as you can see, stenosis of the dorsalis pedis and plantaris medial arteries. You can see the improvement after the distal angioplasty. It was more because the symptomatology that she was present to us, but she will get better from the symptomatology. Symptomatology improved, and she is free from claudication, walking normal. The anticoagulation total to her, it was 6 months of rivaroxaban. So just to show you the laboratory tests from the admission of the three patients. Pay attention for the values of the dimmer that was low, as they was mild case at all. So what did we learn? We know that the pandemic caused a severe acute respiratory syndrome for coronavirus too, involves in addition of the cases of alveolar pulmonary injury and acute respiratory failure caused to cardiovascular disease, thrombotic events, arterial occlusions, and venous thromboembolism. We know that the angiotensin converting enzyme 2, the receptor for the virus, is expressed on meiosis and vascular endothelial cells. So there is a potential of direct cardiac and vascular involvement by the virus. As the knowledge about the disease was accumulated, it was suggest that the thrombokidiatesis it's cause that is cause endothelial injury and mimics. It seems to mimics episode of vasculitis. It was shown that the virus mechanism of vascular involvement mimics cause some kind of episode like cryptogenic stroke, acute kidney damage, cutaneous vasculitis, and other reports describing different clinical presentations. Indeed, like deep vein thrombosis, mesenteric ischemia, abdominal water thrombosis with or without a commitment of the iliac arteries. It's a different kind of management of the arterial events, like the performing of thromboembolectomy with or without intraarterial fibrinolysis and or without systemic heparinization. The the knowledge of that presentation, especially in the severe cases, cause the occlusion of the great vessels like aorta, and although the performing of the thromboembolectomy, it causes the aspects of this desert flow with no flow in the distal limb, like it seems to appear with our first patient. So abdominal coagulation parameters, it was collected on admission in this study of 183 patients and showed that disseminated intravascular coagulation was common in deaths with novel coronavirus pneumonia, and abdominal coagulation shows that kind of tests, and especially the dimer. Like you can see in that paper, the low rates of the dimer, it's related to the survivors. So it's confirming the mild presentation of the case we are talking about, because it was mild case in the phase of pneumonia, but although these they evolved with an episode of limb ischemia. So pulmonary artery wall thickening due to the hypertrophy of vascular muscle cells. It was caused by the infection of COVID-19, and seems that the impaired endothelial function can be seen in the patients up to 1 year after the infection. So at least 1 year they could present some kind of episodes. And the knowledge about earlier documented, we can see some kind of aspects of the COVID-19 as the post-acute COVID-19, that it's about the patient who presenting maintenance of the symptoms to 4 to 12 weeks, and post-COVID-19 syndrome when they show that after 12 weeks. It occurs with low systemic cardiac arterial function on the long COVID syndrome, high arterial stiffness, and reduced peripheral dilation, and large vessel vasculitis, due the prolonged endothelial cell activation and enhanced thrombus generation and persistent inflammation. So the patient is maintains an inflammatory state that could get him in a thrombotic state, causing some kind of episodes like we saw. And we see that there was microclots in both patients, just mild or severe patients, that contribute to thrombosis, even arterial or venous thrombosis, and long-lasting reduction of vascular density. So it's another aspect that can cause some episodes like that. And there is another case description, another case, just to show you that had a presentation similar, but it was a different kind of management. It was a 57-year-old male, present paresthesia and pain of the left ankle 15 days previously, and no recently COVID infection, but he had no tested. He was present in a popliteal and distal pulse total absent, and a slow perfusion of the medial aspect of the foot. So uh, he underwent a Doppler ultrasound that showed the occlusion in the popliteal artery. As you can see, the thickening of the artery wall in the tibial artery too. Just amplifying to see better. In the external leaky artery too. But that patient was compensated. Even this, it was performed angioplasty with, as you can see, an important injury of the common left common iliac artery, causing an important bleeding. And although it was put covered stent graft, the bleeding was too too severe that he needed a laparotomy, got the open abdomen, and died 15 days before. So maybe that is maybe he was a patient to try the approach that we had with the previous patient, and maybe he was not the unfortunate he had. So to conclude, uh, the coronavirus established a thrombotic state by means of endothelitis, and while there is great risk of thrombotic events in serious cases, the risk is not absent in mild case, even after a period of convalescence from the respiratory disease as well. We can see of the case. But this has a low incidence, and that a small number of published reports making difficult to establish universally accepted treatment criteria and options for cases of ischemia in patients infected by the coronavirus. And in both early and late presentations, a high degree of suspicion should be maintained to achieve diagnosis and initiate treatment as early as possible, as we did in our case. The high grade of suspicion, and we initiate earlier the treatment and some options of therapy that we had successful, and the patient recovered without recurrence of the ischemic episodes, and they did not suffer any kind of sequelae permanent. So just showing you my city, where I was born, and thank you for your attention.
Okay, thank you so much, Doctor. That was an excellent presentation.